Assalamu alaikum. Let's discuss about a different topic called Ogilvie syndrome or acute colonic pseudo-obstruction. What are its risk factors? It can happen after major surgery, traumatic injury, severe infection, electrolyte derangement like hypokalemia, hypomagnesemia, and hypocalcemia can cause colonic pseudo-obstruction. And the medication like opioid, anticholinergic, and neurologic disorder like dementia and stroke. Clinical feature there is abdominal pain, abdominal distension, vomiting, and obstipation. Tympanic to percussion, decreased bowel sound. On abdominal examination, if you percuss, there is tympanic, bowel sound is absent. If perforation, there is guarding, rigidity, and rebound tenderness. If we do X-ray, in Ogilvie syndrome, there is colonic dilatation, normal hostra, non-dilated small bowel. So X-ray show colonic dilatation, normal hostra, and non-dilated small bowel. In CT scan, again colonic dilatation without anatomical obstruction. Treatment is NPO, NG suction, or rectal tube decompression, neostigmine if no improvement within 48 hours. Look at these stem. This 67-year-old man comes to you with abdominal discomfort, distension. 5 days ago, there is large volume water diarrhea 6 to 8 times after eating a new restaurant. Okay, there is mild abdominal cramp, nausea, but no fever, chills, vomiting, bloody stool. Okay, his bowel movements abruptly stopped yesterday. After this loose motion episode, now his bowel movements abruptly stopped yesterday. The diffuse abdominal discomfort and distension worsened. Abdomen is distended, tympanic to percussion, distended tympanic to percussion, mild, tender to palpation, no guarding, bowel sounds are decreased, diarrhea reveals an empty rectal vault with no evidence of bowel, blood, and enema. Abdominal CT. There is abdominal CT shows diffuse colonic dilatation with non-dilated small bowel. Leukocyte count is normal. Testing for CD is negative. So, what is your diagnosis? It looks like Ogilvie syndrome, and it happens due to as there is vomiting, so there is electrolyte abnormality, and electrolyte abnormality can cause this Ogilvie syndrome. So, this patient, his diuretic use and recent diarrhea, his diuretic use and recent diarrhea causing this Ogilvie syndrome. Recent diarrhea due to foodborne gastroenteritis, likely caused by electrolyte imbalance, hypokalemia, hypomagnesemia, which can precipitate Ogilvie syndrome. The disorder may largely result in autonomic disruption of the colon. Accordingly, other common causes include severe trauma, severe infection, major surgery, and other causes. There is severe abdominal distension, CT show colonic dilatation, no anatomic obstruction, colonic dilatation, no anatomic obstruction. Management involves valve rest, NPO, placement of NG, and rectal tube for nasogastric and rectal tube for colonic decompression. Neostigmine can be given IV if symptoms fail to improve after 48 hours or if cecal diameter on imaging exceeds 12 centimeters. Then we should which is a strong predictor of impending perforation. So if cecal diameter is more than 12 centimeter and if symptom fails to improve after 48 hours, we should give neostigmine. And option A, an endoluminal mass can lead to mechanical colonic obstruction. In mechanical colon obstruction, in addition, these patients' CT scan showed likely demonstrated mass if they were large enough to cause if it were large enough to cause obstruction. Colonic hypoperfusion can lead to ischemic colitis, which can present with hematochezia, abdominal pain. Colonic dilatation is not typical. And intramural histolytica can cause hematochezia, liver abscess. So that is acute colonic obstruction or Ogilvie syndrome. It's a very wonderful topic. Hope you enjoyed.